I'm my guest today. I'm Jim Mold. My guest today is Becky Purkaple, who's a family physician practicing in Grand Rapids, Michigan. I met Becky when she was still in medical school in Oklahoma, and she was one of those people who um, liked the idea of goal-oriented care from the beginning. Maybe you could say a few words about what attracted you or what intrigued you about the concept.
Well, yeah, I think one of the things that was so intriguing about the concept, and I think one of the reasons that I jumped onto it really early in my medical education was that I had been a patient, right? So I'd had a lot of medical problems when I was younger. And I remember just thinking, and my dad's a pediatrician, and so I had a connection to this medical world where, it just felt like, you were just you know, a chart. This is back in the paper chart era when I was a kid, right? So you're just a chart. And I knew when I got into medicine, I didn't want that, right? I wanted to make sure that my patients, I don't know, felt like people because I know I did not feel like that through a lot of my journey as a child going through medicine. So that was something that was really important to me. Um, and I got really interested in healthcare delivery. And when I was looking to do research in between my first and second year, I was talking to the director of the program. I said, "Yeah, I really am interested in, how we deliver care. Like, I love the cool things, the cool, innovations we have in medicine. That's awesome. But we have so many people who don't engage and don't interact with the medical system because of, lots of different factors. I'm really interested in that question." And he said, "Hey, you need to go talk to this guy named Jim Mold." And I remember being very nervous going to your office and just listening to you talk about goal-oriented care and how it was such a paradigm shift. I immediately was like, yes, this is where we need to go, right? This actually engages the patients in a meaningful dialogue and does everything that I had, like internalized, like, you had put words to things that I had felt and had never been able to like vocalize. And I remember that meeting very distinctly because we also talked about banjo playing. Um, and said, "Oh no, this is what we need in American healthcare and probably all healthcare." But again, I'm an American, so that's my background. So that's how I got into it was again applying what I had felt as a patient, talking about, switching the entire way we do care to make it about what the patient in the moment needs and what their goals are was just like, oh yeah, this makes logic, like this does not, not rocket science. It makes logical sense. And it's what we don't do
So we
in,
did, we actually,
our
we
system.
So we actually had a chance to do a research project when you were in medical school. I think you did a second one when you were in residency.
Hmm.
Could you tell us a bit about those two studies? They were randomized crossover trials, probably the only randomized trials that have ever been done in goal-oriented care. And we were trying to see if we could prompt doctors to actually pay attention to what mattered to patients.
Yeah, yeah. And yes. So, again, I think because it was something that once I sort of saw, once I sort of saw this new pattern of thinking, I said, oh man, this is awesome. Everyone will probably jump onto this bandwagon really easily. So, there's a little think a bit of naivete when I jumped into it going, oh yeah, we can just prompt doctors really easily to make these switches. And so the first one we did, we just said, hey, let's just have the patients, we'll do a little, pre-survey, just like all the paperwork you fill out when you go to the doctor. We'll put in some goal-oriented questions and see if providers do anything with that information. We'll give it to them and see. Um, and the answer was it didn't that was not enough of an intervention to really evoke anything. They would reference it. It was very interesting, I thought, because it wasn't that they weren't reading it, because several providers referenced the prompts that we gave them on the form. It just they didn't know how to fit in those pieces. It was too ingrained to go through the problem-based methodology. I think that was always the interesting point was they'd pick it up, they'd mention what was written down and then immediately go back to a problem. And they just could not make that sort of jump between, oh no, this is this is a patient goal. Let's see if we can actually translate that into care. And it just did not happen very often. And so
What about the
that
second
was really
study?
tough.
So that simple prompt didn't work.
Right. So then we tried to, let's say if we prompt the provider to ask the question. So we'll get the provider to ask a goal-oriented question. We did a quality of life, very open-ended, generic question. And all, the intervention was you have to just ask the question. Because we thought, hey, this way, like they're like engaging in it. In education, we would do this with teachers where we'd give them certain prompts to ask students to flip the classroom. So it was sort of in my mind based on that like ideology. And again, it was even more fascinating because they would have these moments of interaction where the provider would for a moment like enter into this goal oriented realm because patients had great answers to these questions, right? Patients jump on this pretty easily because again, I think this is more automatic for the patients and it's the providers who've been sort of trained elsewhere. So all that to say, it was so fascinating because they go on these nice little tangents. Sometimes they'd even last, 30 seconds to a minute in this sort of goal-oriented quality of life questioning. And immediately it'd be like, and now back to your A1C. And you're like, no, you were so close, right? You were in it. You were in it. You just had to connect, connect these things together. Um, and so it was again, it sort of said, hey, there is this block. There's this wall that we are running into with providers. And again, I think in both studies, what was so interesting is the patients really didn't need any prompting, right? Patients had no idea these questions were coming. They could come up with answers to quality of life questions really easily, but it was the providers who could engage in sort of the human side of it, right? And talk about the goals. I remember one encounter they were talking about, she wanted to be able to walk the mall, like walk around the mall, and she couldn't do that, right? They were able to engage into that for a little bit, but to bring that into medical decision making that was just not there. That was just not, unfortunately, there. So it's a little more complex of a problem than I thought when I started out, which is the summary of my two studies is, hey, how to help providers do this. It's a little bit more difficult than previously thought. So
Yeah, I mean, I think it requires a mind shift and some training. I
hmm
haven't given up hope, but the problem I have is just convincing people that it's worth doing. Um, so, how have you taken the concepts of goal-oriented care into your practice, and how difficult has that been? And what advice would you give to people who want to try this?
yeah. Well, one, and not just to hit on buzzwords, right? But I really do think goal-oriented care helps a lot with burnout, right? Because I think burnout especially in primary care, is that we're not connecting to our patients. We're not, entering into their stories. We're not like getting to know them, right? And the goal-oriented care, and when you actually phrase the entire visit based on goals, I feel like, oh, all of a sudden I know more about their story and they're more comfortable sharing about their story, right? Because all of a sudden I'm on their team, right? I'm not some person who's yelling at them for their BMI and telling them they need to do this vaccine and that vaccine, right? I'm a person who knows what they're wanting, right? And I'm designing their care for them. And so, one, patients love it, right? So I constantly, and again, I feel like I'm a mediocre doctor. I don't feel like I'm a super genius or, a wonderful diagnostician. Like I feel like I'm solidly average, right? But I will get above average reviews. And I have patients that will not see other providers because they know that, they get the sense that, oh, wait, no, you know, they'll say, you're the first doctor who's ever asked me like what I want to do that I can't do now, right? No one's ever asked me that. Um, and I give them the space for it. I will say it does take a little more time. That's always been the thing I've run into is that it takes a little bit more time partially just because of the way the office visit's set up. By the time I walk in, the patient's already kind of closed and stressed, right? They've waited for 20 minutes in the waiting room. They've done this. So sometimes it takes a few visits to get them sort of to go, oh no, this is what we're this is how we're going to do this visit. So I will say it takes a little bit more time, but not as much time as you'd think, right? I think that's the biggest hold that people say is, well, this is just another thing to check off my list, and it's going to take more time, and I'm already stressed for time. In the end, after you get your patients on board with this, I feel like it actually saves me time, right? But it's not it's one of those investing time up front so that on the back end you have more time. Because once patients sort of understand this is how our visits are going to get set up, they're ready to go. They have their goals. They're excited to tell me like, oh, I made it 3 blocks since last visit, right? We're doing it. And so, but it does take a little bit of time initially to sort of set up and reframe it for the patient. I feel like it's more reframing it based on the system. But it, again, a little bit more time in the front end. I think it saves me time once my patients are involved though. Um, the big thing is being able to let go of your agenda as a provider. And that's, I think, the hardest thing because, you go in, you do your pre-charting, right? You need to talk about this problem and this problem and this problem and this problem. And you sometimes have to let that go. You still need to, right? Right. We still need to make sure their diabetes is being treated. And honestly, it comes, right? If you trust the process and trust the goal-oriented method, you will hit all those problems because all those problems are actually what's getting in the way of their goals. But you have to sort of let go of, I'm going to go down this list, and you have to sort of enter into that conversation, seeing where it takes you, trusting the process. And it does work, but you have to trust it going in. Kind of like diving into a pool, you just got to go. If you get nervous, you're going to belly flop. So,
So everybody wants to know how this is going to affect their quality metrics.
oh man, yes. Well, the good news is no one's hitting their quality metrics. So the fact of the matter is, quality metrics have lots of inherent problems. But honestly, generally, I think I don't want to say this, and I love my colleagues. It's not a competition, but I think I might be the best provider with quality metrics in my office right now. So all that to say, not a competition. You give doctors lists and percentages, it becomes a competition. We're all type A overachievers. Um, but I have had no problems hitting my metrics. In fact, I find it a little bit easier because again, all of these things that are part of these health quality metrics um are part of the quality of life, right? Like your diabetes, your blood pressure, all these things are going to affect your quality of life and are going to affect your goals. And you as a provider, once you sort of switch it, you're not going down this list, but these things come in, right? The quality metrics are quality because they do actually affect the quality of life of our patients for the most part. Some of them are ridiculous, I will say. Some of them you're just like, why? Why is that a quality metric? But for the most part, a lot of these are tied to that quality of life piece. And so when you're going through, especially using the quality of life sort of aspect of goal directed care, which is not the only, not the only pillar of goal directed care, but is one that comes up a lot, right? Especially in chronic care management. Um, when you do that, you actually hit your quality metrics, or at least know why you're not hitting them. Um, I have a really sweet 95-year-old patient whose A1C is 12, and I don't think we'll ever get that A1C down. He is 95 and doing just fine. And so he will always be, we've talked about it over and over again, and his cookie a day really brings him joy. And at this point, you know, do I really care about his A1C of 12? No, I really don't. Um, and so again, yes, there are situations like that, but for the most part, you do hit them. The hardest part about quality metrics, right, is you want to click those boxes during the office visit. So really coming up with ways where you don't have to chart that during the office visit is very important, and using either some of the new software or your, assistant staffs and things like that. But there's some technical things you can do to try to help with the inherent box clicking that goes with quality metrics. Grumble, grumble.
Do you do annual big visits or not?
Like annual physicals
Yeah,
or annual wellness
annual
visits or
preventive visits where you focus on and survival as a goal.
I really try with all my patients to do a preventative care visit. I've run into a lot of issues, and these are more healthcare system issues where, so I can hit it with my Medicare patients pretty easily because I can sort of piggyback it on the annual wellness visit. But my patients who are on the, are really underinsured, those are the ones who I'm struggling the most with, because they only come in for their annual physical, right? And they have a laundry list of problems because they can't afford to come in, when their deductible's $10,000 and they make $30,000 a year, right? So running into some major issues that are systems based to get patients in the door for preventative visits and getting their care covered, which is a separate issue, right? But also very pressing in modern society. But for my patients, on Medicaid and Medicare, I really can get those patients in to do preventative care, and the patients love it. Um, Again, you have to sort of sell. They're used to sort of coming in and having to fight for their problems to be addressed. So I found that I have to work through their problems, and once we sort of work down that problem list so that they feel like their problems are well addressed, that's when I can say, okay, now let's actually come back and do a really good goal focused visit. And it's delightful. I get wonderful stories. I learn all about, again, their parents passing and how those things happen, but also how they want their life to look. And especially in my Medicare population, you know, also dealing with a lot of difficulties in aging. Things were not as we expected. I expected to be able to do these, and working through some of those health related, psychosocial things as well come up just naturally when you're bringing in goals, which is what we want as providers.
Becky, it's so great to see you again and
Oh,
hear that you have been able to implement this in your practice and that you
yeah.
find that it's a worthwhile thing to do. And I appreciate your thoughts about this for other people who might be considering
Oh,
drinking
yeah.
the Kool-Aid.
Yeah. No, and if anyone ever has questions about drinking the Kool-Aid, please, 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 give them my name and number because this is something I love talking about. And the students that I precept, it's amazing. They're interested. So I'm toying with getting a study set up, where I want to work with students and see what happens to their goal-orientedness over time. Um, but that's a study for another day, but it's been something I've been brewing on. Because again, students and even early residents jump on this idea. Somewhere during residency, I feel like that's when we lose the ability to do this. So I'm very curious as to like when this moment happens, right? When are we so jaded into the problem-based system that we can't flip back over to a goal-oriented one? But that's a study for another day. So
Let's keep talking about it. Thank you very
yeah,
much. Have
thanks
a
so
great
much.
day.
You too. It's so good to see you.